happy to be here, and thank you for the opportunity. First of all, I just wanted to have the opportunity to make a couple of announcements. And first is that we actually now have a multidisciplinary liver tumor board, which meets on Wednesdays at noon. Everybody's invited. There's so much interest and expertise. It's been really exciting. Turnout's been pretty good. It may have to do with the free lunch, but you know, we do have that. And because of all the interest and expertise, we're proceeding with our first annual UC Davis Liver Tumor Conference. Sorry, I think this is mine. Which I just found out is going to be October 27th and 28th, which is a Saturday and Sunday. And that's going to be at the Conference Center on campus. It's going to be great. We're going to have a faculty dinner at the Shrem Museum. At the end of it all, we're going to have wine tasting at the Mondavi Center. There's going to be a day and a half of case presentations and lectures and panel discussions, and it's going to be great. Everybody's invited. And within minutes of finding out those dates, I had confirmation from Dr. Yuman Fong, who's kind of a guru in robotic surgery. He's actually a guru and expert in everything, if you know him. But specifically, we'll ask him to talk about robotic surgery and hepatobiliary surgery. And also Dr. Ed Wolin, who is now at Mount Sinai, who's a guru of neuroendocrine tumors. And I also found out that one of those 2 days is going to be Dr. Galami's birthday, so you can all come and help her celebrate her birthday. So today, I guess the key word is perspective. And my apologies for this gratuitous clip here, but I'll try to integrate it anyway. I was taken on a nice, calm, clear, sunny day at our own University of California, Davis Airport. Who knew we had one? And yeah, it's kind of distracting, so, you know, there it goes, yeah. And the pilots survived, so it's all good. So today it's a little bit different. I just kind of want to give a perspective on liver transplantation, you know, not from the weeds on the tarmac, all the topics that I could give a lecture on, hepatitis C, hepatocellular carcinoma, the surgical techniques, and not from 30,000 feet where you get into the ethics of, you know, scarce resource utilization and so forth, but somewhere in between, maybe 5,000 feet or so, where you can still see some detail, but also maintain a perspective. That's the goal for today. So I want to talk about a little bit about the disease prevalence, the future utility of liver transplantation, something about the evolving indications, but mostly I want to answer a lot of the questions that, you know, are swirl around the notion of a new program. So I'll try to address those. First of all, I just want to correct, I did not start the first liver transplant program at UC Davis. That's why the title is version 3.0. As it turns out, this is a little flyer from 1983. This is a consensus development conference at the NIH. And it was at this conference that liver transplantation emerged from the experimental to what soon became standard of care. And the bottom line is, it's when insurance companies had to start paying for it. And I actually was around just in all the liver transplant programs in the country outside of Pittsburgh, for the most part, started after this. I happened to be around, there was only 12 at the time at UCLA in 1984 when the program started there. But the first program in the Western United States was actually right here at UC Davis. Dr. Ward was a vascular surgeon here. And I think everybody agreed at the time that probably it wasn't a program that should persist. They weren't quite ready for all the attention to detail that's required for good outcomes. And then about a decade later, somebody came along and started another program. And that program was quite successful all the way up till the time at which it ended. And there is no human being that I've met so far that can explain why that happened, and it's kind of a blow to the institution, and I think one that needs to be rectified now with 3.0. So perspective, just there's always a over 100,000 people in the United States waiting for transplants. Most of those are patients waiting for kidney. These numbers go up and down relative to one another. There was a time when there were more like 18,000 people in the U.S. waiting for liver transplants. It kind of goes up and down, but the proportions stay the same. And this is the standard pie chart depicting the major disease indications that lead to the need for a liver transplant. And you can see hepatitis C is more than 50%, and there's hepatitis B, and then there's some of the other diseases. And so the first question I think that people think of is, well, we're all vaccinated for B, and there are dirt cheap antivirals that can treat hepatitis B. So, that with time should fade. And we all know for the last 2 or 3 years that in 90 days with 90% certainty and $90,000, you can be treated and cured of your hepatitis C. So it's probably more like $120,000. But in any case, it seems like maybe the pipeline, as you look down the road into the coming decades, might be emptying out of all the baby boomers and their hepatitis C related issues. So is there really going to be a need in the future for liver transplants? So this is a recent CDC map showing our age-adjusted 12, this is mortality, deaths per 100,000 throughout the United States. And you can see there are worse places to live than where we are. And it also begs the question is why on earth there would be any liver transplant programs in Utah. When you look at the epidemiology of cirrhosis in the US, this is an article from 2015, the prevalence is almost 0.3%, which in a country of 380 million people is well over 800,000 people in the United States with cirrhosis. And I'm going to argue in a couple of minutes that the greater, catchment area for us is more like 5 million, which would imply close to 15,000 patients in the neighborhood who might be cirrhotic. Cirrhosis remains one of the major causes of death in adults. It's the 4th largest in the 45 to 55 age group, and surprisingly 7th in the 25 to 44. Awful lot of ICU admissions. Of course, these patients are really sick and burn up a lot of resources. I guess you can see this, over $13 billion in annual charges estimated. And you can't talk about cirrhosis without talking about hepatocellular carcinoma, since cirrhosis is itself a pre-malignant condition, and almost everyone with hepatocellular carcinoma is cirrhotic, and all of those patients need to be screened and surveilled for the development of tumor, and then when they show up, the treatment, part of which includes liver transplant. And when you look at the indications for liver transplant over the years, a lot of the things that used to be contraindications are now not, like select cholangiocarcinomas, some neuroendocrine tumors. We actually had an epithelioid hemangioendothelioma patient the other day that we trundled off to UC San Francisco. Even colorectal cancer is developing quite a bit of interest in terms of the utility of liver transplant. And HIV, this is something we did at Cedars when I was there. And then all these other things, the patopulmonary and portopulmonary hypertension that used to be contraindicated in the past are no longer. And I think we lost Dr. Ali, but the metabolic syndrome is not, a happy thing for the liver. Non-alcoholic fatty liver disease is apparently now the most common entity in the liver disease in the Western world, 20 to 30% of the general population. And I found a little bit of information from the NIH that suggests up to 10% of children in the United States also have fatty liver disease. So, and of course, fatty liver disease can progress to steatohepatitis and cirrhosis and tumor, and those are the things that lead to the need for liver transplant. So it turns out probably liver disease is still going to be a growth industry for some time. I've listed some of the other diseases here. What I haven't mentioned is acute liver failure, which occurs at a rate of about 4 per million per year. These are people who have no chronic underlying disease. By definition, they're healthy and fine. They ate a mushroom or took too much Tylenol, and now they're going to die in the next 48 hours or so without a transplant. And they don't always pick where they go, so it's sometimes nice to consider being able to treat those patients as well. But the big tickets are going to be alcohol and NASH, and these are some heads. So that pie chart's changed. The new number one, and maybe if we have time at the end, somebody can ask me about this. Alcoholic liver disease, including acute alcoholic hepatitis, which is surprising, but true, is the new number one right now, and number two is NASH. So the indications are evolving, and probably liver disease isn't going to go away, nor will the need for liver transplants. But everybody's probably heard, there's going to be some changes to organ allocation, and maybe that is a good reason to pause, and maybe that's going to be a problem as we go forward. So just to bring you up to speed, this is kind of two maps of the U.S., the donor service areas that correspond with the organ procurement organizations are depicted on the top map, and we actually have our own up here where the arrow is, and then of course we're in region 5. There are 11 regions. It's always been worse in terms of the ratio of donors to recipients in our region. And in fact, there are problems throughout the United States and ongoing continual efforts to try to improve the equity of organ allocation. Oh, this is just how things were in the past. Probably don't need to belabor this other than to mention that it went from something very subjective to something more objective in 2002 with the advent or adoption of the MELD score that we're all familiar with. And there's this little vestige remnant of status 1 that comes up every now and then. There is no status 2 or 3 anymore. But those are the acute liver failure patients and patients with and kids. We share regionally for scores over 35, and there's kind of a national threshold of transplant at 15. And we have a regional review board, and we have exceptions to the MELD that are discussed by the board, and that's how it is now. So the new proposed and adopted proposals by the UNOS board in just December are 8 mathematically optimized districts, and here they are. Suddenly now we're affiliated with Montana or whatever, Alaska. The donor service areas persist. The MELD sharing goes down to 29. There's some concentric circles, and Dr. Hirosi's brother is behind all of this stuff, so you can talk to him about it later. There's some points given to maintain locality, and then there's a national review board to confer some consistency to the whole review process. The bottom line is, I was at all the meetings, and while it's going to improve the lot for a lot of places back east and the Midwest and so forth, none of these mathematic models and proposals actually improve our lot in California. So it's not going to make it worse, and it's not going to make it better, and I guess that answers that question. So what about existing alternative programs? And I think the first thing here is a quote I heard from one of the regents of the University of California. So you can drive to San Francisco, so the patients can just, they can go there. And also a big ticket is, I hear it every time this comes up, is we don't want to be competing with another UC, with UC San Francisco. So as it turns out, there's some data on this, and it's kind of intuitive that if you're really sick and you're going to die from liver failure, that your distance from the transplant center might be relevant. And in fact, back in 2012, some folks in Texas looked at distance from transplant center versus mortality, And they found out that it became statistically significant at 30 miles. And I think San Francisco's more than that, but we'll look into that in a second. But that might have just been some quirk of Texas. So they actually looked at, more recently, at UNOS national data, and there's this nonlinear correlation between waitlist mortality and distance from transplant centers. So, of course, everybody makes their slides on Sunday morning. I know I did. This is a little screenshot from my phone on Sunday morning from my house to UCSF. And you can see there, if I want to pay the tolls, and this is Sunday morning, and there's no better time to try to get there than on Sunday morning. It was still going to be a 4-hour round-trip endeavor, or up to like 10 hours if you don't want to pay the tolls, I guess. And I drove there recently with my son, and the notion of a 2-hour drive is absurd on a weekday. So if you're really sick and you have to make, I think to undergo a liver transplant evaluation is probably 10 visits in itself, then the maintenance, and then when you get really sick, it definitely seems plausible that distance from a center is impactful. So on the topic of the organs that come out of this OPO and the impact that a program here might have on the UC system is hopefully depicted here. I think these are numbers from 2016, not 2017, but of the, I think it was 64 livers that came out of our OPO here. 11 went to UCSF. That would represent 6% of their total. 6% of UCLA's total, and then 1 went to UC San Diego. The rest, more than 60%, went somewhere else, to any of the other programs in the UC system. And how to explain, when I was in LA and there was a donor here, well, most donors aren't perfect. There's some issue, they're overweight or diabetic or old or something. And if there was a donor here and it was offered to me in LA, I have to think about renting a Learjet and flying up here and looking at it, because the only way you can tell if a liver's good is to actually to put your hands on it. You can't tell by the numbers of the age or any other parameter. So you actually have to go and look, and that's easy when it's in the next room. And it's expensive when you're flying around and in Learjets to just look at an organ. And then the cold time's longer and so on. So a lot of those organs don't get utilized. So if you can wrap your head around the notion that a local transplant program can go look at those organs, and you can go look at them all. And some of them, they wouldn't be great if they had to fly to Utah or San Diego or someplace. But if you're just taking it to the next room and sewing it in, then you can use those organs, and that benefits everyone. So I think it stands to reason that if there is a local program, the number of organs that come out of an OPO goes up by some, I don't know, I'm guessing 15%. That helps everyone. And this is UC Davis versus UCSF. So, right now the majority of the patients, as far as I can tell, that are referred for liver transplant from here actually don't go to UCSF. They go to Stanford or Cal Pacific. I'm not sure why that is, but if the structure of a program, we could actually circle the wagons and actually help UCSF by sending more of the referrals to them. So, and then there's all kinds of room for academic collaboration, for trials and studies and so forth. So I really don't think, I take issue with the notion that a transplant program here would somehow negatively impact UCSF. And hopefully Dr. Hirosi's taking notes. So what about the number of programs and volumes? I mean, aren't there already too many liver transplant programs in the country? Yeah, this may be true. And how could we ever have enough volume to justify having a program? And the implied logic there is you have to do hundreds to justify the infrastructure, and you have to do hundreds to be good enough to be in the game. Because, we think of UCLA and UCSF, and they do hundreds. So let's just look at a sample of adult programs in the Western world here. So UCSF there is at the top. They did 173 in 2017. But look, some of these other places you've heard of, Stanford, Cal Pacific, Scripps in San Diego, UC San Diego, Cedars, University of none of these places do over 100. And so if you look at, it's a little bit hard to get a handle on exactly how many transplant programs there are, but there are about 124. About half of them do less than 50 a year. 20% do between 50 and 75. 11% do close to 100. And only 25, that's 99 of the 124 programs in the US, do fewer than 100 a year. So clearly, you don't have to do 100 a year to be in the game of liver transplants. And let's just talk about the number of transplant programs and their distribution. So, this is easy to do and fun. Just looking at UCLA and Cedars, they're 4 miles apart. Cedars and USC, 11 miles. UCSF and CPMC are less than 2 miles apart. Stanford is over 30 miles at least. And then Utah, there's 2 programs there, and they're 11 miles apart. And then Scripps and UC San Diego are 13 miles. And then don't even talk about New York or Houston, where there are so many programs you can throw a rock and hit a couple. So I think distribution is relevant to the topic. And then we can talk about, well, you got to be doing a lot of these things to be any good at it. So beauty part about transplant is all the data is flapping in the breeze for everyone to see. And so here we are, we're looking at, so this is UCSF, and whatever date range, they did 183. And this is kind of a rough guide for how aggressive they are. It says per 100 per year, okay? And then this is the new system for gauging outcomes, and they're better than expected. They're a 5 out of 5, so they're great. And CPMC did 57, but they're so that's not that many, but they're still really good outcomes. And then as you look down at Scripps, pretty good, a little bit more aggressive. And then if you look at the next, because it's really hard for me to see here, Keck, they're as expected. UCLA is actually worse than expected, 137. Loma Linda, worse than expected. UC San Diego is definitely worse than expected. So it seems like the argument of volume versus quality doesn't really, correlate. There are some data from a few years ago, I think, establishing plausibly a minimum threshold for doing enough to be, to have a well-oiled machine and have good outcomes. And that number is more like 25 or 30. And I think probably, I'm not sure I'd want to be at a really big program where they're just cranking everything. You can kind of lose control. Obviously, UCSF is doing a good job. UCLA, might not be right now. But all of the high-profile catastrophic events have always occurred at huge programs where probably they lost a little bit of control. So I think it's probably better to fly between, the 50 and 100. So, quality is definitely critical. So how would we go about estimating the volume that we could do potentially here? I could say anything, and I still don't know the answer, but I tried to think about it. And this is California for 2017, the number of recipients and the number of donors. And they roughly correlate. And if you drill down, And now these are not the same organs. The organs can go anywhere. They can go to the whole region or the nation. But at the end of the day, or at the end of the year, this is how many recipients and this is how many donors. If you look at the OPO in San Diego, it's kind of interesting for a couple of reasons. Number one is it's like an island because there's Mexico, the Pacific Ocean, I don't know, Camp Pendleton and Arizona. And so there's 3 million people there. And they recovered 84 organs that were transplanted, 84 livers that were transplanted somewhere. And the two centers there transplanted 71 individuals. So, again, there's a little bit of a rough correlation. If you look at the Donor Network West, which is what serves the Bay Area, 13.2 million, 248 livers, recovered, 294 among the 3 centers transplanted. And again, it's not that far off. And the same holds true for One Legacy in LA, 19 million, more recipients and more donors. But if you look at our little island here, which is 2.6 million, there were 64 livers recovered and transplanted somewhere. Obviously, none of them were transplanted here. And if you throw in the possible or probable increase with a local program and you kind of squint and turn your head, then, you could probably argue, and I am, that we could do well over 50 liver transplants a year, probably in the 50 to 60 range. And, our potential referral area does not correlate with the donor service area. So I think it's one of those things where if you build it, they will come. I think there's 1 million people in Fresno County. Everybody in Central California either has to go north or south to get their quaternary care. I think many of those people would be happy to come to Sacramento, given the option to avoid the Bay Area or to LA. I think that circle, which it could include part of Nevada, would be in the range of 5 or 6 million. So, and as Dr. Farmer pointed out on Friday, Sacramento is a happening place. It's the capital of the 6th largest economy on the planet. It's fastest growing major city on the West Coast. And traveling to San Francisco is increasingly challenging. And it's not really distance, it's time anyway. I know that from being in LA, and especially if you're sick. So what about advantages of a liver transplant program to the institution or to the community? Well, I think it's obvious the patients and community would benefit. The institution, we can't get into it. There are financial considerations. I think there's a element of perception in terms of being a full-service quaternary care referral place. And then there's the issue of referrals in general. And I learned this a long time ago. I would get a patient referred for transplant by whomever. And they would come and we would see them and we would laugh because, of course, they're not a candidate for a transplant. But they're a candidate for a resection, or they're a candidate for chemoembolization, or one of the other things that we offer. Or someone's referred for a resection and, oh my God, there's no way they're a candidate for a resection, but they're definitely a candidate for a liver transplant or one of these. And you can also convert. Patients move between all of these, and when you take one of these out and send them somewhere else, they all that care goes with them. So all the things that we could have been doing here, are lost. Then there's the impact to education and training. And I think it was, Dr. Galante can correct me, but I think in 2011 there was a big discussion about the utility of transplant rotations to surgical training. I think the abuse was obvious, and you don't end up doing a liver transplant when you're a resident anyway. So they ended up mixing it up and changing it to an experience and whatever. But one of the things, if I recall correctly, that came out of that was that organ recoveries are actually worthwhile, worth going on. So I would encourage anybody that has the opportunity to go. And that it also impacts everyone else. So medicine residents and fellows, I've listed, all the people that are involved with managing liver transplant patients, GI fellows, the radiology residents and fellows, even blood bank people train here. But if they train here, they're not getting any exposure to liver transplant. And when you leave a place like this and you go out somewhere else, you're going to, even if you're a surgeon and you go into private practice, you're going to encounter people who've had liver transplants. And so I think it helps to just have it demystified by having had some exposure. So yeah, organ recoveries are kind of, we travel for that. It's the only good way to get around to LA. And organ recoveries, it's just, I can't overemphasize, it's a huge operation. There's not always somebody there for all the other organs, and you have to, cut ureters and dissect out the retroperitoneum and see anatomy like, nobody gets to see it. And that really translates into the rest of your career, no matter what it is you're going to do. I think it's really valuable. Even the back table, we flip the liver around and cut it up and sew things together and look at the arterial anatomy, and that in itself can be very instructive. Other advantages to an institution, there's a kidney program here, largest in the country. We're starting a heart transplant program. A lot of heart transplant individuals have cardiac cirrhosis, or they have some underlying liver disease. And when at Cedars we did a whole lot of dual organ transplants because it became obvious that some of these patients, even though they didn't qualify, everything else being equal, for a liver transplant, putting them through the pump and all of these things, some of them failed, their livers failed after the surgery, and so, sometimes it makes more sense to replace them both. And a lot of liver, kidney disease that's related, and we did some long cystic fibrosis liver transplants as well. And then there's all this crazy stuff. Now, the other day, there was a patient presented from the cardiothoracic service that had aortic surgery and then had liver failure after. And Dr. Farmer asked, well, is there any way this person could have been a candidate for a liver transplant? And I said no, but I kind of lied, because the truth is you can do crazy stuff when you have the option. Obviously, that person wasn't already listed for a liver transplant. But their liver's dead, and that's their problem in the short run. And it's not that hard to take the whole liver out. You just plug the portal vein into the vena cava. And it sounds crazy, but it's happened to me too many times. You take the liver out, and the patient gets phenomenally better, because their only problem was their liver was dead. And of course, you think, geez, maybe you don't need a liver because they're doing so well. As it turns out, in a few days, you need to find one for them. But then that's where the status 1 thing comes in. You can push the button, do an eval, and list a patient as a status 1, and they're going to get the next liver from the entire Western United States, or District 8, or whatever it is we're going to be in. And you can do that and save a life. And it's obviously not a common thing, but it's an option only if you have a transplant program. And then I have to insert the obligatory gratuitous surgical clip showing the magnitude of the surgery, and then bring up things like living donors. This is, just a variation on a theme. We're dividing a liver in half, right lobe left, with the vasculature intact. And then, here's the same bit of liver, transplanted into the recipient. And this is another, option, not one that we would probably want to embark upon in the first year or two, but it's just a variation on a theme. Yeah, you're trying to get the blood flowing in there, But there are times when this definitely makes sense, and it's a really good option, and it's another thing that I think we should look forward to. So there's a lot of interest and expertise, as I said here. We have all these things in place. There was a few bits that we would need to add, but version 3.0 I think makes sense with some reasonable additional resources vis-a-vis a hepatologist, some nursing and administrative help. I think, as I said, we could do 50 to 60 livers per year within the first few years. And I think it's, there are real advantages, obviously, to the patients and the community and to the institution. And there's one last thing that, it's always struck me, and that is, as healthcare providers, we want to offer what we do. And what's available and what we're comfortable with. And we don't always do a perfect job of offering what somebody else does and what we're not all that familiar with or comfortable with. So it just would feel better, for the institution if we had all the options available. So, takeoffs are optional, but landings are mandatory. So. And the pilot survived, so it's all good. But I think it's the right thing to do. I think it's the right time to do it. I think there are an awful lot of advantages. And now I have to let the video play out a little bit so you can see that it all worked out. Yes. So, these are the things that keep people in the game, This is a lady that we literally decided was too sick to transplant and stopped care. And a week later, she was still around. So we ended up doing a dual organ transplant. The anesthesiologist and I almost came to blows because she was not going to put this woman to sleep because she was obviously too sick. But of course, I wouldn't be telling you about it if, a few weeks later, she wasn't looking pretty good. So those are the kind of things that are very gratifying. And then the final picture is for those who think these people don't exist. These are not random strangers. These is actually my son and my wife. So they do exist. I am married. I have a kid. And I want to thank everybody for the opportunity. And I'd love to have questions if we even have a couple minutes. So.
Well, Steve, thank you for that transparent conversation about what is a conversation that's happening all around us right now, and I think has a huge impact on, this region, what we're going to do, who we're going to be, and I think it's a great thing to talk about in a very transparent way. So I think we should definitely open this up for conversation.
Yeah, I mean, if you look at Sacramento, the growth, and you just, think a few years down the road, it's hard to imagine not offering, full service. So any questions? Happy to.
Dr. Hirose, why don't I put you on the spot, and then I'll, Dr. Dirkman.
Thanks, Steve. That's a great talk. I think it's interesting to come to Sacramento and try and start programs that may exist 100 miles away that seem esoteric at times, like liver transplant or fetal surgery. But I think that is really important in terms of selling these is for people to realize and to teach them that it's not even about the one operation or the therapy you're offering. There's like you alluded to, there's all these other things that come with it. The non-transplant patients, the radiographic studies, the IR studies, and procedures that need to be done. And I think that there's a clear patient benefit, but the fiscal benefit's pretty clear as well. And one of the things I think people forget is that a lot of these patients are fairly portable. So if you have a choice, most of these people actually would choose to stay near their home, believe it or not. Even the people that you might say, oh, they're sophisticated, they're going to go down to UCSF, but people don't want to travel for their care. But it's actually true. So I applaud your efforts. I think we can have a long talk over several, maybe many years. The challenge
Well, thanks, and I just want you to communicate that sentiment to your sibling, because I don't want them to feel threatened. Like in our dreams, we would somehow negatively impact, the 800-pound gorilla of UCSF. I mean, that's hubris that we'll never have. But I do believe that if we build it, they will come. In LA, we see lots of patients from the Central Valley. They got to go somewhere, And I would feel so guilty seeing people from Fresno and Visalia, in my clinic, and I'm like, oh my God, I don't really have anything to talk to them about. But they just drove from Visalia, And so, yeah, if people have an option, I think they'll come. And we just need to be mindful of quality and, yes.
Really enjoy your talk, Stephen. I love your vision about expanding the programs here to offer. And just to say, but if I was UCSF, I would be quaking. It goes, look at our kidney transplant. So I think it's legitimate, and I think let's go for it. I think we have every.
I have a really good friend who was the best man at my wedding. He's a surgeon in Palo Alto, and his wife, who will go unnamed for many reasons, is a very key transplant professional at Stanford. She's coming here for her kidney transplant eval for obvious reasons. So, yeah, you may be right there. But, yes. Oh, sorry.
Just a quick question, Steve.
Yes.
I have to confess, a little bias here, because my favorite operation in the world was I was a resident, was doing organ donation harvesting. I just thought that was...
Procurement. Sorry, recovery.
Procurement.
Recovery.
I just thought that was the most terrific thing in the world. Do surgeons, the transplant surgeons, still do the recovery, or is it done by technicians?
Yeah, it's done by the surgeons, and part of that discussion about running Learjets and all of that stuff is, when you're gonna tee up a patient to receive an organ, you actually want it to be you or a member of your team who's making the assessment. So there is actually a guy, a good guy who locally here recovers livers, and he's a great guy. But when it comes to, is this organ going to fit our recipient? Is it going to be good enough, and so on? I either want to be munching on it myself, or have my fellow or some member of my team doing it. And I think the same is true for hearts. You don't really just farm it out to whomever is local and take their word for it, because the stakes are too high. So you really want to go look at it yourself to make that determination, and especially when it's marginal, because that's the hard part, is determining. If it's obviously perfect, then it's a no-brainer. But it's all the others, the majority, where you really have to decide, is this going to work? Is it going to work for our recipient? So, yeah, and it is a great operation, and it just translates into a knowledge of anatomy like nobody else has. So, it's great.
Steve, I enjoyed that. The business is local, the network is big. You mentioned in your talk a number of centers where it looked like big centers were shoulder to shoulder, and I'm sure they shared certain resources, et cetera. And it occurs to me
no.
They just
Sorry.
compete outright.
Yep. Yeah.
I was thinking as you delivered your chat of the enormous infrastructure which supports this sort of effort, transplant immunology, et cetera. Some of it is here, for consultation advice. Sometimes that expert, other opinion is just a phone call away. Sometimes more difficult. I guess my question relates to what willingness there is or is not to play nicely in different corners of a sandbox. It sounds
Well, this would be a unique circumstance where there are two UC hospitals. And when I was here before, I drove over at the invitation of Nancy and John and Jack and Jean, and had dinner, and we started talking about all the potential, because I wasn't going to go away, so they had to basically talk to me. And so we were talking about all the collaborative things, and then they were coming over to have dinner with me, which I thought was really telling, that they were going to drive over to have dinner here. And then that's when the Stanford UCSF debacle intervened. But otherwise, there were going to be some nice collaborative, arrangements between two UCs. And I was already sending the path specimens to San Francisco. But I just want to say, a lot of things weren't here then, and now they are. We didn't have a patopathologist back then. Now we have 4. And this just goes in every direction. There is nothing missing here save for a dedicated transplant hepatologist and some other, various and sundry resources. So thank you very much for the opportunity today. Thank you. And, thanks.